last lecture, guys. Beautiful day. Thanks for staying. There we go. All right. So rotator cuff tears, our patients will often tell us what their pathology is. Oftentimes these patients present with lateral deltoid pain, difficulty sleeping on their shoulder, and weakness. Physical examination, I'd like to stress, you should always check the subscapularis. It's often missed, whether it's a Gerber's liftoff or a belly press test, and I find it very useful to watch how the patient lifts their arm over their head, whether they can generate a force couple, and if they have a drop arm sign with the eccentric contracture, irritating them, and basically their shoulder will drop down. In terms of rotator cuff prevalence, you can see here there's a few takeaways from this slide. The first is it's a degenerative process, as Dr. Robertson said, and it increases with age. The second is it's relatively common as we get older. And the third would be not everyone with a rotator cuff tear obviously needs surgery. So like Dr. Robertson, I always insist on x-rays, much to many patients' dismays when they come in with an MRI. But you can see things like calcific tendonitis, seen in this image, as well as the shoulder balance, which I think is very important. Secondary images are very useful. I like CT scans with arthrogram contrast, especially with multiple operated on shoulders when they have implants, particularly stainless steel implants. I think this could be very useful. Also, you can still see muscle atrophy, which I find very useful in treating rotator cuff pathology and staging. Actually, the Goutallier classification is based on CT scans. And ultrasound is also very useful. A lot of us have ultrasound in our office now. It's dynamic, it's readily available. I think it's very good following postoperative patients, but I find it difficult to see labral pathology, and I find it very difficult to see the amount of muscle atrophy and wasting. MRI, I think, remains the gold standard, but again, artifact is an issue, particularly with previously operated stainless steel anchors. So when should we operate? I think there's multiple factors. The biology of the patient is very important. Age has a negative impact on healing, as well as smoking, diabetes, and obesity. And just a couple days ago, I heard a lecture at ANA that shows hypocholesterolemia actually limits healing potential in people with rotator cuff tears and repairs. So also, I think patient expectation is extremely important. So whenever I talk to a patient about a rotator cuff repair, I will tell them that this is a full year recovery, which I think puts things in perspective, and I think it's very useful for the patient to realize this going into surgery. Also, I'd be aware of unexpected repairs that you may not, that the patient may not be expecting. So they may need a rotator cuff repair, and they were expecting just a debridement or subchromal decompression. And I think the subscapularis is often underdiagnosed in terms of its pathology. Also, calcific tendonitis after debridement, oftentimes patients are left with a relatively large defect that needs to be repaired. And also partial tears. Oftentimes with partial tears, secondary imaging isn't always perfect. So I have this patient that came to my office just a few months ago, and he's a 58-year-old male that presented with a spontaneous biceps rupture and pain in the contralateral shoulder, and we actually imaged with MRIs both sides. And at the time he returned with imaging, he had no pain and very minimal weakness, and he demonstrated large to massive tears bilaterally. So this is somewhat of a dilemma in terms of how to treat him. I mean, it's very hard for me to recommend surgery to a patient that has no symptoms and very little weakness and no pain. So these are the types of patients that you really have to counsel them on the benefits of surgery and the expectations of surgery. He elected not to proceed with surgery, which I think for him was the right answer, and he's going to follow up with me in about 6 to 12 months with a repeat X-ray or repeat MRI. And I always go over surgical expectations, as this is a surgery that's very good for pain relief, but not always for strength generation. And also, I warn these patients that an innocuous injury can create a rather dramatic decline in their function, because sometimes the rotator cuff is truly hanging on by a thread. So there's multiple techniques, open versus arthroscopic. I perform arthroscopic rotator cuff repairs because I can visualize the pathology much better. If you do perform open, I think that's fine. Just make sure the deltoid's preserved. I prefer a lateral position to beach chair, but again, that depends on surgeon preference. And there's many ways to fix the tendon to the bone, and there's quite a few ways to pass suture. So you can look at this as glass half empty or half full. I think it's nice. You have multiple options. You have a full toolbox. Anchors and transosseous fixation can both be done arthroscopically. Anchors, there's multiple materials, which we could talk about. Most of them have pluses and minuses, obviously, and there's variable sizes. I'm partial to the triple-loaded anchors because you have more option for fixation, and yet, especially many of us who operate in surgery centers have to think about the costs of these repairs. This article came out in JBJS from Sugaya, which redefined the anatomy of the rotator cuff footprint, particularly the supraspinatus in terms of the small area that it actually encompasses. You can see on the lighter purple relative to the darker purple where the infraspinatus insertion. And I think this is a very important paper for people to perform shoulder surgery, and it was actually republished in the Journal of Bone and Joint Surgery a year later, but I think it has a lot of value. So the big debate of double versus single row, this has been talked about over and over and over, so I'll just kind of summarize what we know with the multiple studies that we have. There's really no difference that have been shown reliably with clinical outcomes. There is a trend toward re-tear rates in single row repairs relative to double row repairs, and we know from these studies that larger tears generally have lower healing rates. Park, in his study from the American Journal of Sports Medicine, showed that larger tears tended to have a better outcomes with double row repair, but to me this is kind of a catch-22 because the larger tears are always the harder tears to perform double row repairs on because you have less tissue to work with. But the bottom line is we need to recreate the anatomy, consider the tear geometry, and also recognize if you perform significant amount of double row repairs, there's an opportunity for medial row failures. And revising these are challenging because you lose a lot of tissue. So partial tears. When you're presented with partial tears, what's the research behind whether to take the tear down or perform a trans tendon repair? Generally, a lot of surgeons will use a 50% rule, where if it's less than 50%, we'll leave it alone and debride it, and it's greater than 50%, we'll repair it. There's no great basic science behind this. I will say there's a corollary to this rule. If you treat throwing athletes at a high level, you really want to avoid repairing rotator cuffs. And you can let it get beyond 90%. They will not be happy with their result. So there was a study in 2012 that looked at trans tendon versus completion of tear repairs, 48 patients. The trans tendon repairs had a slower early recovery, and they had greater pain in recovery. They also had decreased function in the long run in terms of range of motion. However, they did have no re-tear rates in that group and 2 re-tear rates in the completion of tears. And this data makes some sense because when you repair a partial or a pasta lesion in a transtendinous technique, you tend to advance and repair the superior capsule as well, which will tighten the shoulder. So when you have a massive tear, how do you proceed? Tissue releases are very important. Anterior and posterior interval slides can be useful. You have to realize that sometimes you're altering the anatomy, especially if you believe Sugaya's paper in terms of the anatomy of the rotator cuff. You can perform partial repairs. Burkhardt has a wonderful series with great results. However, there's other series that shows the longevity, the success rate of the repairs are marginal. Tissue patches, I think, are a good option in the right patient. Generally, people have accepted the acellular dermal matrix patches are the best option. And you can either have a patch where you're filling a defect, or you can augment repair. And Dr. Barber demonstrated with large tears, there is good outcomes or better outcomes with the patch augmentation. And then we'll talk a little bit about superior capsular reconstruction, which is in vogue currently. And then always latissimus transfer is an option. And then as Matt talked about, reverse total shoulder arthroplasty is a possibility. This is a technique, the balloon, which is being developed in Europe right now. And it's actually a Vicryl balloon that you stick in the subacromial space and inflate. And the results, I saw a paper, actually I was in Anna a couple days ago, and they're reasonable. So we are developing new techniques. So this is a patient of mine who had a patch repair, 68-year-old male. He had chronic calcific tendonitis, and he never wanted to get an MRI. Ultimately, the calcific tendonitis resolved, but he still had pain and weakness. We got an MRI, and we went in because he had recalcitrant pain. He had this large defect that I couldn't bridge, so I used a patch. The one thing about patches, you have to realize you're using it off-label in tears, defects greater than 1 centimeter. If it's less than 1 centimeter, it is on label for FDA approval. But he actually did quite well and had a contralateral repair, and he's actually happier with his patch side. But again, there's no great data behind this. So the superior capsular reconstruction, which I think a lot of people have talked about, and the reason they talked about a lot of this lately is because of Mihata's study that came out in 2013, and these results are staggering. If you look at the bottom, the shoulder and elbow score went from in the 20s to 93. Unbelievable. If you look at the active forward elevation, 84 to 145 degrees, and he used a tensor fasciolatic graft, autograft. This has been reproduced in our country, and again, I saw a recent study a couple days ago from Burkhart that demonstrated pretty good results. The advantage of superior capsular reconstruction is it does preserve anatomy per se as you're recreating the superior capsule, and you don't really burn significant bridges like a lat transfer. However, if a patient is young and really needs strength, you may want to consider a latissimus transfer still. You have to think about the costs of this surgery. The acellular dermal allograft is $1,000 to $3,000, and you generally use 6 to 7 anchors. So you're not going to be the most popular surgeon in the surgery center if you're doing a lot of these superior capsular reconstructions. And you also have to think about, often these patients have prior attempted repairs, and they already had a humeral side biologic failure, and you're putting you're putting an allograft in, essentially. So Burkhart's paper from a couple days ago that I read, it was a 75% success rate, and they had about a 40% failing rate for healing. And I think maybe some of this is due to the fact that we're not using the tensor fasciolata graft and we're using this allograft. But this is a case that I did. I repaired it with a double row. And the second picture from the left, you see these measuring devices are very helpful because you have to measure out the distances. This is a case I had. It's a 60-year-old male volleyball player who was actually set up by another surgeon on the East Coast for a superior capsular reconstruction. And a couple things you need to be aware of superior capsular reconstruction is you have to repair the subscapularis if it's torn. If it's irreparable, it's not an appropriate surgery. And they shouldn't have arthritis. The data shows if they have arthritis, they don't do as well. But if you look at the picture on the left, that's from the intra-articular view, and you can see the coracoacromial ligament as the trocar is going in through the tear. And I really couldn't mobilize it very well. And the MRI preoperatively reported that it had a normal, or a subscapularis that was intact, but as I looked anteriorly, I didn't see much of a subscapularis. And this patient had a classic anterior superior rotator cuff tear, and if you look, he had what's called the comma sign. As I bring that tissue forward, you can see the asterisk on the picture on the upper right where the subscapularis came over. And again, the comma sign tissue supports Sagaya's paper where there was a lot of bridging across the bicipital groove from the greater to lesser tuberosity of the supraspinatus and subscapularis. So what we did here was repaired in the upper left the subscapularis, and the next two pictures on the upper right and lower left shows that left a very reparable supraspinatus infraspinatus tear. So we'll see how he does. So when you have these massive tears and you're trying these repairs and using these patches, we need to look at what the research shows in terms of rehabilitation. Generally, I don't have these patients go to therapy for at least 6 weeks. And they've studied this with randomized controlled trials over the last several years, and these studies have shown no differences in outcomes and function at 1 year. However, these underpowered studies have shown significant re-tear rates, 23% versus 9% and 15 versus 9%, favoring later rehab and a limited early rehab. So when you send these patients to therapy, you have to be mindful of what they're doing and how aggressive the therapists are going to be. So you need to have a practical approach and think about the patient's biology, and I follow these patients very closely. This is a 65-year-old registered nurse who had a unique failure, well, or almost a unique failure. She had a double row rotator cuff repair, and I was very happy with the repair. And she went to therapy. In about 8 weeks, she was telling me, oh, the therapist thinks I'm too stiff. He's making me cry at the end of the sessions. And we actually got an x-ray, and the tendon actually pulled and elevated up the anchor, as you can see here. Fortunately, the tendon healed, and she ended up doing very well, but we had to revisit what appropriate therapy is for her. And to me, for these large rotator cuff tears, slow and steady wins the race. We can deal with stiffness rather than a failed rotator cuff tear. So thinking about complications in rotator cuff repairs, there's mechanical or biologic. Oftentimes it's poor tissue. Generally, the failure is in the tendon, not the bone. That was pretty atypical. Infection is something to consider. There's rarely a staph infection or a very fulminant infection, but the indolent infections are very interesting. And this paper, again, is kind of a paradigm shift looking at how prevalent these Propionibacter acnes infection are. 68 revision shoulder arthroscopies performed for pain, stiffness, or weakness. And a quarter of these had positive cultures for Propionibacter acnes, which is something to be mindful of. And if you perform open shoulder or arthroplasty, if you culture a lot of these previously operated shoulders, you find a lot more Propionibacter acnes than you'd expect. Some surgeons advocate doxycycline for a couple weeks after surgery, and they also will point to the fact that doxycycline is a protease inhibitor that may improve healing as well. So it's an idea to consider. Looking at outcomes, I know it seems a little obvious, but healing rates correlate with outcomes, as Harriman pointed out, and JBJS. The comparing outcomes is very difficult because there's multiple types of rotator cuff tears and repairs, but generally it seems to be around 20%, and larger tears have poor healing rates. So my predecessor, one of my former partners, I found out from patients, used to always tell the patients, the number one risk factor for a rotator cuff tear is a prior rotator cuff repair. And this just is very humbling. It kind of shows you the challenges of rotator cuff repair, and we have to be realistic about our outcomes and expectations. So you really want a quality repair without tension. You have to think about the biology. I wouldn't underestimate the subscapularis. I think it's often overlooked. Recovery time and expectations are important. Like I said, I tell patients a year recovery. And I'd be very careful with inflammatory arthropathies because they just behave differently. They don't heal as well. And you have a large toolbox, so I'd come prepared. The beauty of rotator cuff surgery is there's multiple paths, so it's a fun way to treat patients.